Hi everybody. Okay, so let's go ahead and get this one started. There. Okay. So this first week is just a really truly an introduction to pediatric nursing and kind of what that means. So there's not going to be a lot of details given for each of these topics because each of the topics will then come into play in the following weeks. So we're really just going over the basics, giving you some ideas of when you're doing the reading, how to focus that reading, and then we'll end with some pediatric math, okay? So with that being said, main objectives here, and please remember, go back to these objectives, and actually looks like I forgot to put the math on here. This is what I make your exam off of. We go by the objectives to make sure that we're checking all the boxes and hitting all the things that you need to have. So identifying key concepts like patient family-centered care, traumatic care, therapeutic communication, etc. We're together in here, we're going to briefly compare the differences in assessment of kiddos and infants and comparing that to adults, because that's what you know so far as adults. Going over that family-centered care a little bit more. Talking about national pediatric health goals and how that applies to Alaska and what we've done with it. Looking at our state health goals. Talking about some essential clinical skills that while you won't be able to practice hands-on, later on in future rotations, like in your role transition, your leadership course, and last semester, if you want to be in the ER, some of this will come up. And then talking about some brief stuff with hospital stuff. Okay, I keep this slide up here because I think it's really important. As a nursing student, you're never going to know everything, right? Even as a new grad nurse in your first year, you're never going to know everything. So the way that I teach from this course is from this concept-based learning perspective, where we combine critical thinking, clinical judgment, and competence. So critical thinking and clinical judgment get mixed up pretty frequently. Clinical judgment is something that you will continue to develop throughout your whole nursing career, just like your critical thinking skills. The difference in clinical judgment is as you gain more experience, your clinical judgment grows. I think of it as like a repertoire or like a repository of all of the experiences that you've had as a nursing student and then as a nurse. Because your assessment of some wet sounding lung sounds and your decision on what to do will probably be very different from day 1 as a nurse to, year number 30 as a nurse. In your day 1 as a nurse with those wet lung sounds, you're going to feel a little apprehensive. You'll probably go and ask somebody else to take a listen and help you figure out what the right terminology is and what the first priority to do is. Versus year 30 as a nurse, you'll hear those sounds, you'll know what to do, you'll take action, reassess, follow up, etc., etc. So it's something that you will continue to deposit information into. Your critical thinking skills, however, is something that you are having to have at this competent level before you can get out of school. So that is making the decision as the new nurse when you hear wet lung sounds that I know that this isn't right. I'm not 100% sure what I'm supposed to do. I'm going to go get someone to help me figure that out. Year 30 as a nurse hearing the wet lung sounds, your critical thinking is going to make the connection to, okay, so wet lung sounds, I know this patient has congestive heart failure. I know that now this patient's probably in fluid overload. I'm going to call the doctor. We probably need something like Lasix to help get off some of this excess fluid so that they can breathe better. You have critical thinking skills now. You're going to continue to have them. My goal and my job is to help you further develop those critical thinking skills so that your clinical judgment can grow. And your clinical judgment as a student grows with every chapter you read, every exam that you take, every question you get right, and also every question that you get wrong, okay? And so all of that together results in competence. Are you a competent and safe nurse? And that's what NCLEX is looking to see. So that's the perspective that I'm going to take for the rest of these 6 weeks with you, and how we develop these skills for you. So when we're talking about pediatric nursing, there is one main goal, and this trips everybody up every time. So I want you to take a second and think, what might be the main goal? Is it healthy kids? If it is healthy kids, how do we get there? And the answer to that is health promotion. So the main goal of pediatrics is to improve the quality of healthcare of all children and families. Within that, we're looking and striving to provide equal opportunity and resources for all kiddos of all socioeconomic statuses, all demographic locations, etc., so that they can achieve their fullest health potential. And that is so important, because if you think about access to healthcare conversations, what does and how does access to healthcare impact kiddos if we have different standards of care for kids in different regions of the United States? It would look really different, and it'd be hard to promote that equal healthcare and high quality health for kids if we have that kind of distinction. So health promotion, in that we're promoting equal opportunities and equal health standards for all kids, is the main goal, because we really want to decrease those disparities, those differences, and along that line. So why do we take it from this perspective of health promotion instead of tackling the acute problems first? Well, I'm going to tell you. Normally I would ask this question, but now it's just me to tell you. So health promotion its definition has these two components. Health promotion integrates surveillance of physical and psychological and physiological and emotional changes, and incorporates that assessment of it. So we're really doing screening for depression and mood disorders, for risk factors for type 2 diabetes and childhood obesity, while we're also assessing their current health status. So it's all rolled into one. And so health promotion provides this nice overarching kind of catch-all for everything that we want to do in pediatrics. Now, how is it used? The definition kind of gives that away. It is providing screening and early assessment, early intervention, providing acute care when needed. It is providing referrals for resources for socioeconomic stuff that families struggle with. It is providing, we're going to talk about early intervention next week, but it's providing early intervention for development delays to try to prevent them from getting worse. It is providing really, you can take it back to the holistic approach to health, and that's how we use health promotion in pediatrics. So a few ways, like bigger picture ways that health promotion is used. We have our state initiatives. So Healthy Alaskans 2020, and they don't have a cool logo just yet that I could find that I could pop in here for Healthy Alaskans 2030. That is our state initiative that is modeled after Healthy People 2020. And is that next? Yeah. Healthy People 2020. And really what they've done is taken a look at what are our biggest issues in the state, and then narrowed that down even further. Okay, what are the biggest issues among the biggest issues, and creating some objectives and then starting to tackle those. This is the link for Healthy People 2020 and 2030, and Healthy Alaskans 2020 and 2030 are both in your learning materials and are part of the prompt for the first part of the prompt for your reflective journal. So I want you to take a look at these. Look at the pediatric ones. what do you find to be the most surprising? For example, what is something that you thought would be there but maybe isn't? Or what is something that you didn't think would be there but is? And so these initiatives, based from this health promotion standpoint, are used for a multitude of things. One, public health uses these. They have these objectives help put out programs, help solicit funding for things that we need in this state to say, this is the goal that we're working on, this is why, this is what it addresses, here's what we need for it. Another example, my own personal example for my DNP project, my scholarly DNP project, I used our state initiatives and used the data and the objective under adolescent mental health, which is horrendous in the state. That's one of the biggest issues that we have currently in pediatrics in the state of Alaska. So I used that objective and that data to spur my project, and that's what I based it on. So there's like I said, a multitude of ways that these are used. For your purposes right now, I just want you to be aware that these are the things that are going on in this state. These are the current relevant issues that we have among the pediatric population in the state. And so then when we think about the national initiatives based on Healthy People 2020 and then Healthy People 2030, again, that's what our Healthy Alaskans initiatives are modeled after in looking at kind of these big bucket ideas of the big issues that we need to look at. So switching gears a little bit, bright futures. I don't know if we have any parents in the class. If we do, I'd be curious to hear your experiences with Bright Futures in your well child checks with your kiddos. So anticipatory guidance is a huge concept in pediatrics, and I'm going to be asking you to think about anticipatory guidance in everything that we do, from these early weeks of health promotion and the normal well child to the very end when we're talking about kiddos with acute care issues coming into the hospital. Because anticipatory guidance is just what it sounds like. It is that guidance that we as nurses give to parents so that they know what's coming up for their kiddo, how to prepare for it, what to look for. So Bright Futures is a national initiative, a national health promotion initiative to address anticipatory guidance. I have a huge, like 400-page book of Bright Futures anticipatory guidance. That one's very in-depth because I'm a pediatric nurse practitioner, but usually what you'll see like in the offices or even on the floors are quick one-page notes for you as the nurse to give to the parents. Excuse me. With that anticipatory guidance. So overall, Bright Futures looks at promoting family support, normal child development, mental health, and healthy nutrition. And so when you think about what does that mean for me as the student right now, how does this play into how am I going to study for these exams and what does she want me to know? Anticipatory guidance and Bright Futures all roll into that health promotion standpoint that we're looking at. And so if you think about what falls under those buckets, family support, child development, mental health, and healthy nutrition, from a prioritization standpoint, things like safety and injury prevention, number one. Safety is always number one. In peds, in adult, that is our priority. We're making sure that patients and families are safe. And in kids, we're really also looking at that injury prevention piece. So what does that mean in an example? So, a kiddo comes in for their 6-month well child check. At the end, the nurse is going to provide anticipatory guidance to the parent about what to expect between the 6-month check and the next check, and which, depending on the practice, could be 8 or 9 months. And so what kind of things would you tell that parent when we're thinking about injury prevention? Well, at 6 months old, they're going to start scooting if they haven't. They want to put everything in their mouths. So making sure that toxic substances are kept up higher, putting child locks on everything. They're going to be mobile soon if they're following healthy development. So looking at getting baby gates already. Those are the kinds of pieces that fall under anticipatory guidance when we're thinking about safety and injury prevention. Also under child development, then we have healthy weight and physical activity, because child obesity is a huge issue in pediatrics. So is oral health, especially in the state of Alaska. Then not forgetting our teenagers and that, upper end of development in pediatrics, so sexual health, activity, and development. And then there's a big emphasis in Bright Futures in that anticipatory guidance piece on the importance of community relationships and resources. So those were a lot of examples. If you wanted to break it down even further for yourself, for buckets to kind of clump things into when you're studying, based on everything I just said, I come up with 3 major themes for all ages and stages that captures all of those things we were just talking about. So, development, that growth and development piece, which we are going to dive much further into next week, that's number 1, because that's going to capture so many pieces of what we're talking about. Then nutrition, it needs its own bucket because it is so important. Again, childhood obesity, type 2 diabetes, sleep apnea, all of those really dangerous things for kids fall under nutrition. So if we can start promoting healthy nutrition from the get-go, hopefully those things will be avoided then, right? And then oral health. Again, especially in Alaska, that's a huge issue. It is a national initiative to address pediatric oral health. So that's your 3rd bucket, okay? All right. So switching gears a little bit, we'd be remiss if we didn't talk about infant mortality and thinking about anticipatory guidance especially. So this is a little bit older. It's from 2010, this data, but I still think it shows a really good picture view of where we in the United States kind of fall. And the current data is not much different than this. We have the highest rate of infant mortality per 1,000 live births, especially compared to places like Finland and Sweden. Granted, when you consider population and all those other factors, yeah, that plays into it, but this is still pretty stark. I mentioned Finland because they have the lowest level of infant mortality, and one thing that they do that we're going to talk about from our perspective in the U.S. quite a bit for infant stuff is this resources piece, right? So the Finland maternity package or the baby boxes, I don't know if anyone's heard of that. It's something that each family gets when they leave the hospital. It gives them a box with all of these supplies. And so that's what it seems like on the surface, right? But you're giving them a box. That is a safe place for the baby to sleep. If they don't have a crib, if they don't have a bassinet, a box seems really simple, but with the right materials and resources in there, it works. It is better than co-sleeping. They get stuff to get started with baby over here, and then they get this continuing guidance and follow-up from nursing. Or their version of nursing over there. And so actually in the state of Alaska, our AHEC program is actually partnering, they were right before the pandemic started, and was going to start a baby box project for our rural families. I know that that's been paused a little bit, but that is something that they're still planning to work on and make sure it gets picked back up, because the data shows that providing these kinds of resources and education really does make a difference. So looking at this one, a little bit more current-ish, up to 2015, shows you where we are in the U.S. With infant mortality by state. So Alaska, while not the worst, is also not the best. You can see down here in the south where we have the highest rates. Looking over here in the west where some of the lowest are, and then this kind of intermixing in between. Again, that's a really stark view of everything, considering in the US we have, advanced technology, but also high costs, and so all of that kind of rolls into it. But when we think about infant mortality, again, remember, we're also thinking about it from a health promotion standpoint. So what can we do to promote healthy infants, healthy sleeping, healthy development so that infant mortality does not occur as often? Okay, switching gears a little bit more, looking at childhood mortality now. 3 big buckets here. We've got accidents, that's safety and injury prevention at home. Motor vehicle accidents is a huge piece. And then you've got your hospital piece with, that could range anywhere from trauma from this, or acute health issues. And one more thing I want to say about that, remember, briefly for this week, everything is done by ages and stages. That stage of growth and development, which we're going to get more into next week when it comes to this mortality piece with the ages and stages. But when you're now starting to wrap your mind around the concepts in pediatrics, start thinking about these ages and stages. Even if you don't know anything else about kids, you know that a teenager is going to be more cognitively aware of things going on than a 5-year-old. Start thinking about what accidents are more prone to the younger kids versus the older kids. Usually it's easier for those of you that have children or come from big families where you would have seen that age spread like that. And if not, that's okay. Still start trying to train yourself to think in that way. What's interesting too, and I don't remember what date this was from, childhood mortality is lowest in the age range of 5 to 14. So I want you to ponder that as you finish out the readings and things for this week and we move into next week with that growth and development piece more in depth. 5 to 14, that's a pretty big range when we're talking about birth to 18 is where we're looking for the pediatric age range. So thinking about how mortality is lowest there, what happens from 5 and under that would cause high risks and high incidences of mortality, and from 14 to 18. So your middle age ranges are the safest per the data, and your outliers, your early and your late, are the least safe. So think about that as we move into next week. Okay, here's another example. Some places have these nice trifolds. Some have, like I said, that one-page handout. And here's one about teeth. So literally educating families about which teeth are coming in, when to expect them to come in, what to do with them, when you should go to the dentist by. All of this is information that families need, okay? And I mentioned even in the hospital when kiddos are sick and are there, it's a great time because you have a captured audience. They're not going to come in and leave unless you're in the ER, and that's a little bit different. But thinking about the inpatient peds floor, if you've got a teenager there from an ATV accident, that is a great time to talk to the family about safety and injury prevention, wearing seat belts in the car, wearing the correct protective equipment, having parental supervision for things that are appropriate for that. It's the perfect time because they're already there. They're there for some kind of injury in this example. And it's a really nice neutral way to provide that education without making it feel punitive. And that's the other great piece about the anticipatory guidance if we're giving the same information to every family, the hope and thought is that there will be less kind of disdain, or you're talking down to me, or don't tell me what to do with my kiddo. If we're telling everybody, you work that into your conversation. So here, example, here's the anticipatory guidance for our 6-month-old well-child visit. This is what we talk to every family about. Now, based upon what I've heard you say today, here, and you can check off for them, here are some key priorities for your kiddo. So we still want it to be individualized, even though we're saying the same thing to everybody. And that comes from your nursing assessment. What did you hear? What did they say? What are you seeing? All right, so new morbidity, that's a term that's used to capture some of the bigger issues that we're seeing in kids now. So that includes academics, that includes being a victim of violence or being exposed to violence, that includes psychological stress and trauma. All of those truly things that you're hearing about in the news prior to the pandemic. Bullying, that's a huge piece of the new morbidity concept. And so that is used to help think about your priorities again, how you're going to assess, what you're looking for. And let's say you were a school nurse, new morbidity and the concepts that fall under there would help you to prioritize and assess your population of kids and figure out what are the bigger issues where you're at. Okay, family-centered care. I mentioned this a few times. It's a huge buzzword. You're going to hear it probably at least 100 more times before you're done. So what is it? It is exactly what it sounds like. It is not just patient-centered, but we're looking at the whole family unit as our patient. That's who we're taking care of. Even if the kiddo is sick and comes in, the family is still part of that unit that we're taking care of. And so when we talk about family-centered care, a huge impact on that is stress. And so in the acute side of peds in the hospital, when you're having families come in, you're seeing them at potentially their most stressed time. They're under duress. They don't know what's going on with their kiddo. Even just something as simple as tonsils being removed or an appendix coming out. If a child's been healthy their whole life, this is a huge piece for the family. And so you as the nurse have to take that into consideration and plan for and adjust for that. So how do you provide the care that you need to for your patient while including the family, taking care of the family all at the same time? And we're gonna dive into that more. Okay, so here's an example. We've got an 8-year-old kiddo on the floor who just had an appendectomy and has a dressing change due. He just woke up. His mom stepped away from the bedside to use the bathroom. So how can you as the nurse provide family-centered care to this family and this child? So with the stuff that I just said, we know that you as the nurse, the priority is providing family-centered care. Your tasks, things that you need to do right now include getting this dressing changed. But he's 8. He's probably scared, right? We're going to talk next week on how knowing their age will help inform your assessment, because their developmental stage is going to come into play here and how you interact with the child and with the family. But for now, what your biggest piece to focus on is that mom is not there. And aside from a kiddo feeling scared without mom, what might some other things that the reasons that we want mom to be there for? Well, it's a great time for mom to see, or any other caregiver to see, what that incision line looks like, what's going on. It's a great teaching moment for both mom and kiddo. It provides comfort and reassurance for mom and kiddo when they're both there. So what can you do? You can come back. You can ask kiddo if he knows, if mom said how long she was going to be, and then plan to follow back up and do that dressing change when mom is there. Okay, another example. A 15-week-old female in the NICU is due for a bath on your shift. Both of her parents regularly visit in the evenings when they get off of work. How can you as the nurse provide family-centered care? Okay, well, it seems simple, right? It's a bath, but it's kind of a loaded question. There's a lot of pieces that come into play during bathing and hygiene, especially for the little ones in the NICU. It's a time for families to be able to bond. It's a great time for the nurse to be able to provide education to families, answer questions. And so, again, what can you do? Plan your care around when the family's going to be there, as long as it doesn't negatively impact the kiddo. Now, if this was the baby needed timed antibiotics, that's different. So you have to use your nursing judgment and your assessment in determining when it's appropriate to rearrange your care and when it's not. Okay, one more. Kind of gave this one away a little bit. A 4-year-old male in the PICU is receiving IV antibiotics, and his peripheral IV has been dislodged, so it's not where it should be. He's got a dose due now. Dad's at the bedside. So what can you do here? Well, the big one here is to what? Utilize Dad. Ask Dad, when is he comfortable holding the kiddo and providing comfort while you as the nurse try to get another IV in? Some families are, some families aren't, but you have to offer it and ask. Because not only is it helpful for the family or the father in this scenario, but it's going to be a much more comfortable and less traumatic experience for a 4-year-old to be held by Dad in a big hug with his arms over Dad's shoulders getting an IV put in versus a nurse who may be less familiar holding his arm or holding him in a big bear hug type of scenario to kind of keep him restrained in a safe way. So you're going to utilize the family if they're able to do that, and then if not, if they're not comfortable with it, you're going to find out if they want to be in the room or out of the room. So it's really, again, incorporating what you need to do while utilizing the family, and especially if this was at night and there was less staff, utilizing the family can provide you as the nurse with more options as well. All right, so switching gears just a little bit, pediatric nursing roles. There are so many, and I specify pediatric nursing roles because, one, we're in peds, and two, it looks a little bit different than adult. So we've got a few different things going on here. We've got, family advocate and providing caring. We have the role of that health promotion and disease prevention. You are the teacher doing health teaching. You are providing support and counseling. There's coordinator and collaborator working with the whole team. You have a role as a pediatric nurse in this therapeutic relationship that we're starting to talk about, and hopefully you're starting to see illustrated a little bit. And then there's the part where you as the pediatric nurse takes this role in ethical decision making, not doing things, we'll get into that a little bit more too, but not doing things unethically. And I know that sounds really silly to just kind of say it blanket like that, but it's true, especially when we start thinking about teenage reproductive health and doing things against child wishes, but parent, guardian, consent. There are a lot of pieces that go into that. And as the semester continues to unfold, we will dive further more into each of those pieces in each module that we have. But for now, just know that there are many specific roles that we're going to talk about. Okay, so assessment of the infant and the child. Really different physically assessing kids and infants than adults. So top things to keep in mind for pediatric assessment. Number one is that the order and how we do things is going to be very different than the head-to-toe physical assessment that you're used to with adults. Why do I say that? Well, I don't know, again, if any of you have kids. I really do miss being in person. But if you've ever been around a 6-month-old or an 8-month-old who has to get their heart listened to or their lungs auscultated, if you've ever even seen a kiddo in that scenario, and if not, I can tell you they do not like it. Toddlers especially, they do not like it. So in pediatrics, we do the least invasive first. So, when you're starting your assessment, that is going to be observing. And I can tell you, my clinical groups in the past would hear it 1,000 times. You are going to get the most information from your physical assessment of a kiddo in those first few moments before you even lay hands on them. What do you see? You can assess gross motor, fine motor, language skills, social skills, cognitive skills. All of that is best assessed without you even interacting with them. And then from there, when we're thinking that physical head-to-toe type of assessment, what is their breathing pattern? Is it labored? Is there increased effort? What are their respirations? We actually have to count the respirations on the kids, which can be hard sometimes. And so from there, when you're finally going to put hands on kiddos, what do you think you're going to do first? Are you going to look at their mouth and look in their ears first, or are you going to listen to heart, lung, and abdomen sounds? You're going to listen to heart, lung, and abdomen sounds first. It's less scary, it's the least invasive, and overall in pediatrics, the theme is to do the least invasive thing first, whether we're talking about physical assessment or labs and testing and diagnostics, that kind of stuff. So it's not head to toe. It really, when we're doing physical assessments, it is run on kid time and kid cooperation, with bearing in mind that you still have to get all the pieces of the assessment. And I have done many creative things. I've seen super experienced pediatric nurses do things I hadn't thought of in order to get the information that you need. There is some lengthy page numbers, a section in the book on assessment of the kid and the infant and the child. I highly recommend you at least skim that part, if not read it in depth, depending upon your comfort level with kiddos. Granted, we're not going to be in person with any kids for clinicals for this semester, but I still expect you to know that same information because it is going to come into play in the exam. And while I will be less likely to ask you a simple question like, what are you going to do first? It will be integrated into the question. So you really do need to know the ins and outs of the physical assessment of infants, children, and teenagers. Remember, go back to that bucket that we talked about a few slides ago of assessment and healthy development, sexual development. In order to be able to assess for those things appropriately, you have to know things like Tanner staging of adolescence. What does that mean? How do you do it? All of that falls under pediatric assessment, okay? So while I'm not going to take the time in the PowerPoint to review that with you because it's stuff that you've had in the past, I do highly recommend you take the time to look at it in the book. Okay, another thing about pediatric assessment is we know, and these are kind of the top ones, we know that different between kids and adults is that kiddos have a more immature blood-brain barrier. So what does that mean? Why do you need to know that? So that comes into play with meds, our dosing schedules, how much we give, how often we give, right? There's a higher respiratory rate. So if you didn't remember at least that kids will have a higher respiratory rate than adults, you might think that their respiratory rate, which is actually normal, is abnormal. They have thinner skin, especially our younger kiddos. So again, why is that important? Thinking about topical medications, thinking about things that kids touch, they're going to absorb more. They have a higher metabolic rate. Again, back to the medications. They're going to process and eliminate and break down meds much differently than adults will. They have a larger body surface area for their age, or for the younger ages and stuff compared to our adults. They have more rapidly dividing cells. So I don't know if anyone's ever heard the term or the phrase that children are more resilient. Typically when we think of resiliency, we think about the ability to cope with very stressful situations and trauma, bounce back, still have a positive worldview. But this truly also means in kiddos, their cells are more resilient. They divide faster. They heal faster and more differently than adults do, depending on the age. But at the same time, they also still have an immature immune system. And we'll talk about what that means as we go on, okay? So, thinking about our hospitalized child and priorities if you were there with them in clinical, and thinking about this list of priorities for exam questions. These are the pieces that you need to take into consideration and prioritize, along with that safety and injury prevention piece. A lot of these: promoting freedom of movement, maintaining a routine, encouraging independence, providing understanding, always striving to provide atraumatic care, encouraging play and socialization still, and then safety. And I put safety on the bottom because we always think about safety, and it's still important to mention here, because I don't want you to forget about that, but it's always at the top with the number one stuff, right? And this list isn't in any prioritized order. But all of these pieces here, as you're going to see illustrated throughout the rest of the course, all of these pieces do what? They encourage the normal growth and development of kiddos to still occur while being in the hospital. And it encourages patient family-centered care, okay? So everything you do, it's going to come back to their normal growth and development. How do we encourage that even if they have a health disruption? And how do we incorporate patient family-centered care into all of this? I just want to put in a quick blurb about SBAR. Huge communication piece. Communication errors in pediatrics can lead to very dangerous medical errors, medication errors, treatment errors. And PEDS has one of the highest rates of med errors. And so we're going to do some stuff with SBAR throughout this course, because I know both from experience as a student and a new nurse, from precepting new grad nurses, to having students in clinical in the lower courses like 400 or 401, and then seeing you again in 416 right before you're done. Report and SBAR reporting, handoff reporting and SBAR reporting are such a huge barrier because you guys don't get to do it a lot, right? When you go to clinicals, when you finally get to go, you're not the one typically giving the report. You're listening. And listening is great, and you learn a lot from observation, but it's always going to be very different than doing it yourself. And so we're going to try to work on those skills for you in this course. Okay, another piece, and you're going to hear this over and over and over, is effective communication with families. And I know that a lot of students, that can be one of their biggest self-perceived barriers or challenges in clinical for PEDS, is talking to families. It can be very intimidating. Like we said before, families are stressed when they're there in the hospital with their kids. It's a very sensitive thing, taking care of somebody's child when they're sick, especially. And so that therapeutic communicator part, how do I speak to a family and provide the health education? Huge, huge concept. And so something that we're going to talk about a lot. Okay. Switching gears a bit, let's talk about medications and calculations in PEDS. I have do's first, but we're going to start with the don'ts. Like I said before, I think in the last slide or so, there are so many pediatric med errors across the nation because everything is weight-based. we're using and working with much smaller numbers than we are with adults, and so that leaves a lot of room for error with decimals and abbreviations and those kinds of things. So using your regular, without even thinking about peds, good math practices, good labeling practices, using approved abbreviations only. So, HR for hour versus, and I can't even think of things that aren't approved because I don't use them very often, or see them very often even. But so we'll use the do's. ML for milliliter, mg for milligram, HR for hour. And so if you're not sure, you can always spell something out. That would be better than trying to make up your own abbreviation and then getting something wrong on the exam because you have mislabeled it. And so that's another piece. You always need to label and have the correct unit or name on your answers, both in real life practice and on the exam. So example, if the answer is 87 milliliters per hour and your final answer is only 87, it's not going to be correct. And I'm a real stickler about that because that piece is so important because there's a big difference in labeling something 87 milligrams versus 87 milliliters. And I need to know that you know the difference. Other don't use a trailing zero. So if the answer is 87 mLs, it's just 87, not 87.0. Why? Because someone could accidentally misread that as 870, and that's a big problem, right? I wrote ped specific, and that's really just relating to how everything's weight-based. And we're going to talk about here in the next slide, because this always trips everybody up. In peds, there's going to be a dosing weight, and we're going to talk about what that means. So good practice is a combination of all those things above. Using the right abbreviations, making sure your units are clearly labeled, having your decimal in the right place, and rounding. So I know from doing this course for many semesters now that students struggle with the rounding in here. Because from my understanding, and it's been a long time since I've calculated adult stuff, if I understand correctly, when you guys are calculating adult calculations, you just leave everything in the calculator and keep going. And in peds, we don't do that. It's always a philosophical debate. Isn't it, students will say, isn't it more correct to just leave it in the calculator and continue using that whole decimal versus using like the dosing weight and taking things out and rounding? I can tell you that even though I don't work on the floor, I work an outpatient and I prescribe meds, I don't leave anything in the calculator. We use a dosing weight. How far you round is truly facility specific. So most places it's going to be the first or second decimal place. My PICU nurse friend, their like PALS stuff and how to calculate all of their meds is to the second decimal place only. I use the second decimal place when I'm calculating medications for kids. I do know, however, I've seen when I worked the peds floor, I've seen kid places use it up to the third decimal place. And I've heard from, Jessica Chambers, who goes and brings kiddos in from rural Alaska into Anchorage, the same thing, facility specific. So if you were going to Prov or you were going to A&MC for peds, when you got there, you would want to know what are their rounding rules, because each place is different. I've worked in 3 different inpatient places with peds, and everybody did it a little bit different. Again, this is usually a question from students, well, why? How is that accurate? This is one of those things that is peds specific, and so it's always good practice to find out what your facility specific rules are. Talking to pharmacy is a great way to do that. And if you want to know why they do it a certain way, pharmacy is a great resource that gets forgotten about. that's who's calculating things and you're checking with. So talking to them, talking to your managers, talking to providers, they can give you that answer. Okay? So, okay, what am I thinking? Oh, I skipped it. Oh no. Okay. So, practice 1, very simple. Provider order reads vancomycin, 15 milligrams per kilogram, IV every 8 hours. Your kiddo weighs 22 pounds. So what is the correct dose? 150 milligrams. Okay, so now I also want to add this caveat. There are multiple ways to set up calculations. And as long as you're getting to the right answer, that's okay. I will tell you on the exams, all of your math, and you'll have math on both exams. They are short answers so that I can see your math. So that I can see if you got the wrong answer, where you went wrong, and help you remediate that better, okay? So I have my work up here. Don't be too thrown off if it's not how you would do it. If you can get to 150, that's fine, okay? So 15 milligrams per 1 kilogram is equal to how many milligrams per 10 kilograms? And that answer here obviously is 150. So it's a pretty simple one, okay? And remember, anything that has pounds, you have to convert to kilograms, and that's a 2.2 change, okay? So I divided 22 by 2.2. And that's how you get your 10, okay? Another one. Provider order reads ampicillin 100 milligrams per kg, IV every 12 hours. Pharmacy sends you up a vial of ampicillin 100 milligrams per 1 milliliter to the floor, and our infant weighs 8 pounds. So what is the correct dose, and then what is the correct volume that you're going to give? And we're asking that because your dose is going to be in milligrams, because you have to figure that out first to figure out how many milliliters you're going to give, which is your volume, right? Okay, so 360 milligrams is your dose, and your volume is 3.6. So here's where I was talking about that dosing weight. Now, to be honest, I know that in Kaplan, it used to tell you in the instructions when you were doing math what to round to. I believe ATI is doing the same thing. I haven't heard any differently. Just like I'm going to tell you how far to round. For any question that has rounding in it, my blanket statement is you're going to use up to the second decimal place. So here, that example, here's that repeating decimal that I was talking about. To get your dosing weight, you're going to look at 3.63 and drop the rest. Okay, so this is all gone. Don't look at that. To figure out how to round to the first place, you're going to look at the second. If this is under 5, which it is, you're going to leave it at 3.6. If this was 3.67, I would round the dosing weight to 3.7. Okay? And to reduce the confusion, reduce as many disparities as possible, for most of your questions on the exams and most of the practice questions on the worksheets, they end up being even numbers as far as weights to try to reduce some of that confusion. There are a few that will have it, but again, this is the way I would like you to do it for my exams, and there will be reminders of that in each question that has a rounded dosing weight, okay? Now, some students would be like, I still don't understand why we don't just leave it in the calculator. So one example of why we wouldn't do that, if the provider came up to you, and let's say it was an urgent scenario, you would not be able to leave this weight in a calculator. You would have to give that provider a weight. How much does this kid weigh? I need to provide, XYZ medications right now. You're not going to say to a provider, 3.63636363, right? Especially even in a code. What's the weight? We have to know the weight because things are weight-based. So 3.6, 3.63, 3.64, depending on your facility's rounding rules. That's where you're getting the dosing weight. And that is very important. Again, I'm not going to engage in the philosophical debate about which one is more accurate. I can tell you in nurse practitioner school, this is how all of my preceptors did it. This is how my school taught me. This is how I did it on the unit as a peds floor nurse, again with slightly different rounding at each facility in some cases. And so this is what's important for you to know. And I want you to be able to understand why there is a dosing weight versus using that long calculation. And I haven't worked adult in a long time, so while I'd be happy to have the conversation with you about how it's been different in your experiences, this is the way that I need you to do it, okay? So with that in mind, that the dosing weight is 3.6 kilograms, we have 100 milligrams per 1 kilogram, which this is how I set mine up, which is then equal to X amount of milligrams over 3.6 kgs, which is equal to 360, which is equal to your X, okay? And if I was writing this, it would be like in fraction form. So when we're thinking about our volume, we've got 100 mg per 1 milliliter vial, which is equal to 360 milligrams over X amount of milliliters, gives you 100x equals 360, so divide that by 100, and you're going to get 3.6 mLs. Another question that comes up, and it's fair, if we're using decimals, how can you be as accurate as possible? Very, very true. And that's why a lot of times on the peds floor, when we're getting things for IV pushes and things like that, they actually come on a pump. And it comes pre-filled. The syringe comes pre-filled from the pharmacy, and they put it on a pump, and it will push on a timed release to help alleviate some of those other errors. Of course, there's always going to be this scenario where you're drawing something up and it's 3.6 and you use your best judgment. 3.5 is clearly labeled, a smidge more, which is not an accurate term, smidge. Just above it is going to be 3.6, because then you're going to look at what the next little dash mark would be, and using your clinical judgment and critical thinking, what's 3.6 going to be, okay? All right, now, this is where most students get super confused, and why I actually moved pediatric math from week 2 into week 1, so that you have an extra week to look at it. The 4-2-1 rule is a way, an easy standardized way that we calculate hourly maintenance fluids. So 4-2-1 is only used to calculate your hourly rate of maintenance fluids. Not your hourly rate for an IV antibiotic, nothing else except for maintenance fluids. Now, there are some similar things out there to 4-2-1 that will get you within like tenths of a decimal place. Sometimes it's one whole number off. But 4-2-1 is how we're going to calculate hourly maintenance fluids in this course. They use this at Prov. I know they use it at A&MC. So if you were in clinical, it would be consistent across the board. So 4-2-1 rule right here. 4 milliliters per 1 kg per hour for the first 10 kilograms of the child's weight. Then it would be added to 2 mLs plus 1 kg per hour for the next 10 kilos of weight. If they weigh more than 20 kilograms, this is where this last bullet comes in. 1 milliliter per kg per hour for each remaining 1 kg thereafter. So let's look at an example. You are admitting a child to the floor from the emergency room. The child has an IV in place and is receiving D5 NS maintenance fluids. Your child weighs 55 pounds. Based on the 4-2-1 rule, what is the appropriate hourly infusion rate? And then what is the total volume the child should receive in 24 hours? All right, so per hour it's 65 mLs per hour. For, was the last one shift or 20? Yeah, 24. So then your 24 would be 1560. So let's look at that and break it down. So 55 kgs divided by 2.2, that gives you 25 kgs. So this is how I set this up. 4 mLs per kg per hour times 10 kilograms is 40. Then 2 mLs per kilogram per hour times the next 10 kilograms gives you 20. Now we're at that 20, so for the next 5 kilograms, you're doing 1 ml per kilogram per hour times 5 kilograms gives you 5. If you add all those up then, 40, 20, and 5, 40, 50, 60, now we're at 65. That is your hourly rate. And then you multiply that by 24 to find out what you would get for a 24-hour period. Okay? Let's look at another one. You are caring for a child in the PICU. The child has an IV in place and is receiving D5 quarter NS maintenance fluids. Your kiddo weighs 18 pounds. Based on the 421, what is our hourly infusion rate? And then how much should your child be receiving on your 12-hour shift? All right. So 32.8 mLs per hour. And then we've got 393.6 mLs per shift. And then if the child weighed 18 kilos versus pounds, because I wanted you to see that difference, it'd be 56 mLs per hour, and that would be 672 mLs per shift. So let's break those down. So when our kid weighs 18 pounds, we're looking at 18 divided by 2.2, and we're getting 8.2 kgs as the dosing weight. Okay? So same setup, and I do it the same way every time just for consistency and to keep it straight for myself. I set it up just like this, like you're seeing. I write it out. 4 mLs per kg per hour times 8.2 kilograms. That gives you 32.8. Now, here's where people get tripped up. The child doesn't even weigh 10 kilograms. So if you're going off of the calculation appropriately, this is where it ends for you, right? So there wasn't even 10, so how could you then do 2 mLs per kg per hour for the next 10 kilos? So you use the whole weight and multiply that by 4, and that gives us that hourly rate, okay? And then for your 12-hour shift, you're getting 393.6 mLs per shift. Now, if the kiddo weighed 18 kilograms, we're going to do 4 mLs per kg per hour times the first 10, 2 mLs per kg per hour times the remaining amount, since it's less than 10, so that's 8. So then you have to add 40 and 16. You're getting 56 mLs per hour for that kiddo times the 12 for your shift. That gives you 672 mLs per shift. Okay, it's a very simple calculation to plug in once you wrap your mind around it. So that concludes your Module 1 lecture. If you have questions, remember I have office hours. I put Wednesday because I'm actually recording this Monday morning, so I'd be able to connect with you on Wednesday. You can shoot me email questions as well, as long as they're simple. If they're going to be an involved question, let's find a time to get on Zoom, even if it needs to be outside of office hours, okay? I hope this was helpful. I really look forward to reading all of your journals this week. And then I will get everything up and ready to go for next week. So the module will open at 12:01 on Monday morning, and everything will be popped in there. And then I hope you guys have a great day.